Well, hello, fellow radiology geeks of the interwebs. Welcome back to another lecture. This one is for those of us that are still studying radiology at undergrad, or those of us that are obviously looking to try and refresh our knowledge and understanding of these conditions and these findings on your images that you're taking in clinical practice and you just haven't seen them for a little while. But like I said, this one is mainly aimed at those students out there that are coming up to their semester exams and things like this. So thank you very much for joining me. Today we are going to be discussing the how to differentiate between malignant and benign tumour processes. These are of primary bone lesions in particular, just to clarify that one. So let's get into it. So the learning outcomes for this lecture are: you will be able to differentiate between benign and malignant bone tumour processes with greater confidence. You'll be able to describe these lesions in greater detail. You'll be able to use appropriate terminology when writing your reports as well, in particular. Now, this is again for those students who do have to write reports in your exams. If you're anything like my students, then you will do indeed. That is what us radiology lecturers tend to do with you. And obviously to get you through your exams with gaining those higher marks when doing so. So just to recap on the sort of tumour types in when we're talking about primary bone lesions. So we have benign primary lesions, which are non-cancerous lesions but they will degrade bony architecture, so they do have consequences for those patients who have them. Some of these will be expansile, so they'll start off within the bone and they will expand outwards through the sort of medullary canal and through the cortex into the outside soft tissues. But so just because it's benign does not necessarily mean that it's nothing to worry about. I go through this with my students all the time. It is not that a benign tumour process is, sort of paints a picture of it's nothing to worry about and the patient's going to be fine. The patient will be fine, but some of these conditions do require surgical resection, and obviously if we don't, then it increases the risk of us actually losing limbs and losing functionality of the limb. So it's important for us to understand that when we do see a benign tumour, the patient still needs a referral from your clinical practice back to their GP or to an oncologist or a surgeon for that second opinion. Your malignant tumours, these are primary cancerous lesions that can be aggressive or non-aggressive and will spread to other areas of the body. These tumours will invade the surrounding soft tissues around the bone itself, so there is also that local invasion of adjacent structures, but also there are other methods that these conditions can spread by invading and eroding into a blood vessel and allowing to spread that way. Some of them will spread through lymph, and some of them have a soil and seed method where they have an affinity for certain other tissue types, so once they get into the bloodstream they are likely to spread to certain areas that have a high affinity of a certain cell type, which allows them to seed very easily in that area. So these are primary lesions that occur within the bone itself, same as the benign tumours. They are primary lesions that occur within the bone, within the area that you first find them. And then you've got metastatic disease, where this is the spread of cancer from a different area of the body. These are secondary cancerous bone lesions that occur at later stages of the disease. Unfortunately, these are sort of stages 3 and 4. You'll find that the body has lost the ability to fight the cancerous lesion, and so it's capable of spreading to other areas of the body quite easily by that stage, unfortunately. So when we're talking about the difference between a malignant and a primary lesion, there are certain ways of describing those lesions that will lead you down the garden path into thinking whether or not you're actually looking at a benign or a malignant tumour. Now, these findings are not 100% definitive. Once you're out in clinical practice, once you're in your clinical careers, you will have those cases where there's quite a lot of crossover between these findings, but for the sake of your revision and for sake of you getting to grips with this is how the sort of easiest ways to try and break it down in your revision time, in preparation for your exam. So when we're trying to tell the difference between a benign and a malignant tumour process, so a narrow zone of transition is when we've got a clear defined margin between the bone tumour and the healthy bone tissue, whereas with a malignant tumour or a malignant process, that tends to be described as a wide zone of transition, because the defining factor, or the difference between where the tumour ends and the healthy bone starts, is actually really difficult to see, and that you might not be able to really see it much at all depending on the extent of the disease process. So when we've got a malignant process, that malignancy is invading the localized bone in the area, it becomes very challenging to be able to differentiate from the healthy bone from the malignant tumour process. Both of these can be solitary or multiple lesions. The reason why I've put this up is because a lot of the times when we're talking about solitary bone lesions or multiple bone lesions, malignant processes will spread to adjacent areas, and so that's one way of seeing where we've got multiplication of that same tumour process elsewhere in the same bone. Or the way to describe it is if we've got multiple benign tumour processes, so we've got a patient with Olliers syndrome where we've got multiple enchondromas within that patient, these are they all look very similar to one another. So the process itself is similar amongst all the different bones that you can see, or the different areas of the bones you can see. So with Olliers syndrome, we've got those multiple enchondromas within the patient's hand. They're all very similar in their appearance. None of them really look much different. So you're not going to see one that's got a periosteal reaction, for example, and another one that doesn't have a periosteal reaction. So they're very similar in their appearance of those multiple bone lesions, whereas with malignant tumours, some will look blastic, some will look lytic, some will have a periosteal reaction and others won't. So if you do have multiples of the same lesion of the same disease process in the same area, they can actually look very different. That's partly to do with the tissue type as well. So with benign tumours, these are typically seen as a homogeneous cell type, because the cells are the same, the appearance is obviously the same. So therefore you'll have a very homogeneous appearance of the bone lesion throughout. Whereas with a malignant tumour, you've got different types of cell within the area. They're of different stages of division and apoptosis, so you'll have a mixed appearance of lytic and blastic within the same tumour itself. This is particularly true when we're talking about a chondrosarcoma, where we've got that malignant tumour process, but there's usually a real sort of central nidus of it. There's a central body of that tumour that is going to be quite blastic or quite sclerotic within it, and then it's got a mixed appearance around the outside of it. So that mixture of different cell types means that its appearance is actually not homogeneous. It doesn't look the same throughout the tumour. Typically, and again I do say typically with this, a benign tumour process will not have a periosteal reaction present, because it's not invading through the cortical bone and taking the periosteum with it. You're not going to see the periosteum lifted in the majority of benign tumours. However, there are cases where, again, I'll show you a case in a little while, where we've got it is a giant cell tumour that is expanded through the cortical margin and is clearly going to have taken the periosteum with it, and there is a periosteal reaction present. But in the majority of benign tumours, and for the sake of your revision, I would recommend that you keep in mind that there is not going to be a periosteal reaction present, whereas with malignant processes there is going to be that periosteal reaction present, whether it's a solid periosteal reaction or a sort of a laminated, or we've got the hair on end, or sunburst, depending on how you want to describe it and how its appearance is. And just of note as well, both of these tumor types increase the risk of fracture of that bone dramatically, leading to what is always going to be called a pathological fracture. Okay, so whether it's a benign or a malignant tumor, if you've got a tumor that's also caused a fracture in the area, then it is going to still be described as a pathological fracture. And here is that case that I was just referring to, where this is we've got a P2A and a lateral X-ray, plain film X-ray projections of a patient's right wrist. We can see the right hand marker is present on the lateral projection. This is of a 30-year-old male who presented with swelling and pain of his right wrist, and we can see where we've got the healthy bones in the wrist, where we've got lovely appearance of the carpals, normal appearance of the distal radius, but then as we look at the distal ulna, we can see how there is this large expansile lesion within the metaphysis, leading down to the diaphysis of the distal ulna. The real sort of furthest sort of articular surfaces of the ulna don't appear to be affected. We can still see the styloid process and obviously the articular margin between the radioulnar joints. However, the rest of the bone you can see has been dramatically damaged as a result of this particular lesion. Now, this is a giant cell tumor. This is one of your soap bubble. If you've if you have a look in your textbooks and you see the mnemonic for your soap bubble appearance, you'll have that fog machine. So we've got fibrous dysplasia, giant cell tumors and things like this, and aneurysmal bone cysts and simple bone cysts. So this is a giant cell tumor, or an example of a giant cell tumor, where it's got that real soap bubble lytic appearance of the actual bone itself, or the tumor itself. But the reason why I'm bringing this case up is because when you see this does not look benign. This, apart from the fact that it's a large expansile lesion with that soap bubble appearance, and it hasn't metastasized anywhere, it hasn't then invaded into the sort of local areas, so we don't have invasion of the tumor into the radius, for example. There doesn't appear to be any soft tissue involvement either. The actual soft tissues themselves are actually quite flat through here, so the swelling is actually the bone expansion itself, but there's no large amounts of tissue invasion adjacent to the tumor itself. So that's an indication that this is obviously more likely to be that benign tumor process. But if we look down here in the distal aspect of the ulna, before we hit the actual tumor site, if I zoom in, we can actually clearly see that there is actually a laminated periosteal reaction here. So as the bone has gone, as that tumor has expanded out through the cortical margin, it has obviously taken the cortical margin out, which you can see here. You can see the end points of the cortices. However, down here we've obviously got that elevated periosteum, and it looks the appearance of a laminated periosteal reaction that's present with this tumor. So that in and of itself will make you think that this is a malignant tumor when it is in fact a benign tumor, which is why, again, for the sake of your revision, it's worthwhile stating that typically there is not going to be a periosteal reaction present with a benign tumor process. This is one of those cases where we do have crossover, where there is actually a periosteal reaction present with a benign tumor process. So it's just worth to keep it in mind for your clinical careers and for your understanding that when you get out into clinical practice, they may not be the case, that it is definitely not going to have a periosteal reaction, but in the vast majority of cases there is not going to be a periosteal reaction present with a benign tumor process. So moving on from that very confusing case of the giant cell tumor, this is your much more typical appearance of a benign primary tumor process, where on this patient's left tibia, we can see the left hand marker is present down here, and we've got AP and lateral projections for us to work with. We can all see that there is this lucent lesion within the distal third of the patient's tibia, and it is found within the diaphysis. These are all keywords and phrases that you all need to be aware of and familiar with and ready to write down in your exams or your coursework. So moving on with that list of descriptive terms that we spoke about earlier on, this is a lesion that is very well demarcated. There is a clear narrow zone of transition between the tumor and the healthy bone tissue. In this particular case, you can see on both projections that there is actually a rim of sclerosis surrounding the tumor as well, so it's very, very well demarcated, and there is a clear narrow zone of transition between a healthy bone and the bone tumor site itself. This is a loculated lucent lesion. It's primarily a lucent lesion. You can see that on both projections. We can also see that there is no soft tissue involvement and there is no breach of the cortex. There is a clear cortical margin that is sustained throughout. It gets thin along here, don't get me wrong. This is starting to really affect the cortex here on the lateral aspect of the distal tibia, but there is still a cortical margin there, so there is no breach through the cortex and invading into the soft tissues, and there is no sign of a periosteal reaction. On either projection there is no sign of periosteal involvement. So therefore, all of those words, all those key phrases, the way you've described this leads you down the garden path into thinking that this is a benign tumor process. The bony architecture is going to be affected with these patients, so this has an increased risk of fracture, and as stated earlier on, this will be a pathological fracture in its description. However, there is no fracture present in this particular example, and this is your example of a non-ossifying fibroma. So depending on where you find these, and I went through this recently with my students, depending on when you find these, if you were to re-x-ray this patient in a few months' time and you look at this and it looks basically the same, or it will look exactly the same, then it is definitely a non-ossifying fibroma. However, when you're looking at an ossifying fibroma, if you were to wait several months and re-x-ray this patient again, you may find that that lucent appearance has actually started to become much more sclerotic, and so that's when you have an ossifying fibroma, and at this stage it just hasn't ossified yet. So in this particular example, it's seen as a non-ossifying fibroma, but we may actually find in your clinical practice that you may want to re-x-ray this patient in a few months' time to see whether or not it's changed at all. Now, comparing that case of the non-ossifying fibroma in the distal tibia to this one, this is obviously the patient's left femur, and this is an immature skeleton we're dealing with. We can see the epiphyseal growth centers have not fused onto the rest of the bone just yet. This has got a completely different appearance, so this is going to be a completely different animal. This has got a very mixed appearance within the body of the tumor. We can see areas of lytic appearance, but there's also that sclerotic or blastic appearance within the same tumor process. So this has got a mixed appearance. We can see how there is invasion through the cortical margin into the soft tissues. You can see some soft tissue swelling around here, around the lateral aspects of the distal femur, and we've got that obvious periosteal reaction that looks like that sunburst or hair on end appearance of a periosteal reaction. You can also see, we'll zoom in on this a little bit, where we've actually got a mixed appearance of the periosteal reaction, because down here we've actually got a more of a laminated appearance where the periosteum has been lifted off the bone, and here is where the tumor has invaded through the cortical margin and taken the periosteum with it. And we don't have a very clear border around it. We can see, we'll zoom in now, on the proximal aspect of this tumor, you can just about make out that margin where the healthy bone starts and the tumor itself stops. However, there is a very wide zone of transition for that to occur. If we move in from where the body of the tumor is down here, move through this area of lytic and blastic appearance, and then move further up, you can see how that zone of transition is not very easy to see. So this is poorly demarcated. There is a very wide zone of transition. We have that periosteal reaction present. Again, we've got a mixed appearance with laminated and that hair on end or sunburst periosteal reaction present. We've got a mixed appearance of the tumor itself with soft tissue invasion around it. So this is, now we're describing a lesion that is much more likely to be a malignant tumor process. So this is a primary malignant tumor within an immature skeleton. So this is going to be much more likely to be an osteosarcoma. So in summary then, we've discussed benign and malignant tumor processes. Some of the words and phrases that are key for your understanding of how you would both analyze these tumor processes and how you would describe them is a benign tumor is much more likely to have that narrow zone of transition where there is a much more visualized border between the healthy bone tissue and the tumor, whereas with a malignant tumor process is much more likely to have that wide zone of transition, very difficult to tell where the tumor stops and the healthy bone starts. Benign tumors will often be described as a well demarcated or well circumscribed lesion with that narrow zone of transition, whereas a malignant tumor will have that poor demarcated border. A rim of sclerosis is likely to be present in a benign tumor process, whereas with a malignant tumor, that mixed or moth-eaten or permeative appearance is often words that are often used to describe malignant tumor processes. Benign tumors are often going to be eccentric. They're not going to be found within the medulla. That is not going to be the case 100% of the time. Okay, so please when it use this video as a guide to structure your revision when you're looking at these tumor processes. Use this as a guide to structure your revision around. However, just keep in the back of your mind that there is always going to be a crossover, and this is not 100% consistent across the board for all of these tumor processes. And the reason why I say that is because benign tumor processes can start within the medulla of the bone and expand outwards. So that's your soap bubble expansile lesions. However, if we're talking about fibrous cortical defects, non-ossifying and ossifying fibromas, then these are always going to be within the cortex, and they are eccentric in their appearance. Malignant tumors are much more likely to have that periosteal reaction that can also be mixed, so you'll have that laminated hair on end and sunburst appearance within them, and the malignant tumors are going to have that soft tissue invasion or involvement as they breach through the cortex, take out the periosteum around it, and invade into the soft tissues. This is crucial for exams for you to better understand this, guys. I hope you found this video helpful, but please, like I say, always keep in mind that this is not 100% foolproof. So for your clinical careers, always keep in mind that these patients will always need further investigations. So if you do have those patients that come in with a benign or a malignant tumor process, when you're describing it, if it looks benign, send them off for further tests anyway. Because ultimately the MRI scans and your CT scans are going to be much more sensitive than your X-rays of being able to decide whether or not these have whether there is any soft tissue involvement or invasion of it around it. I hope you found this video helpful, guys. Like the video, share the video if you found it helpful, share it with your colleagues and your friends to make sure that you're helping them with their revision as well. I hope you find this helpful for your exams and how to structure your revision around. Please like, and if you're new to the videos, please subscribe. It's always very helpful, and I look forward to seeing you all in the next one. Take care, guys. All the best.